In this video, we are going to discuss mainly about diabetes in pregnancy. So, the diabetics in pregnancy is divided into two types. That is the patient who is already having diabetes before pregnancy. That is called as overt type of pregnancy, or also called as pre-gestational diabetes. Okay, and there is another type of patient who is having diabetes only during pregnancy. That is called as gestational diabetes. So there is overt diabetes or pre-gestational diabetes, and there is gestational diabetes. So so what are the features of this overt or pre-gestational diabetes is, in these patients, if you check the fasting blood glucose or fasting blood sugar, that will be greater than 126 milligram %. Okay, these are the very important parameters. And if you take the random blood sugar, even the random blood sugar will be greater than 200 milligram %. And if you take a special test which is used to know the average of blood glucose, that is HbA1c, if this is greater than 6.5%, so these values are very important, which we need to remember. This is a overt or pre-gestational diabetes. That is a patient who is already having diabetes before pregnancy. Okay, and this patient is called overt or pre-gestational diabetic patient. And here the values are, the first one is the fasting blood sugar. The fasting blood sugar is greater than 126 milligrams, and the next one is random blood sugar. It should be greater than 200. And next, coming to other one, that is a HbA1c. This one is greater than 6.5. Then you can confirm it as a pre-gestational diabetes. And gestational diabetes is because of pregnancy there is diabetes, because in between 24 to 28 week there is a high chance for the mother to get diabetes, because there is more insulin resistance, and this is the gestational diabetes. Now coming to gestational diabetes, let us discuss it in detail. So this gestational diabetes is mainly due to HPL. What is HPL? Human placental lactogen. Not only because of HPL, we have discussed other hormones like estrogen, progesterone, cortisol, but the main one is HPL. So because of HPL, there is gestational diabetes. Already it is between 24 to 28 weeks, right? And this gestational diabetes will be most commonly seen in third trimester, greater than second trimester, and it is never seen in first trimester. Why it is never seen in first trimester? Because this gestational diabetes is coming from 24 to 28 weeks. That is nothing but it is mostly in third trimester followed by second trimester, but it is never seen in first trimester. Okay, but in the case of overt or pre-gestational, even in every trimester we can see this. Okay, so what is the screening test for all pregnant female? For all pregnant female, there is a universal screening test which is done especially at first antenatal visit, and also we do it again between 24 to 28 weeks, because that is the time there is a chance for again pregnancy. In the first antenatal visit, why we do the test? Because we want to know already the patient is having overt or not. And on 24 to 28, why we do? Because we wanted to know whether the gestational diabetes is going on or not. So for this two tests, actually we do repeat, remember that between 24 to 28 it's okay, but mainly greater than 24 weeks, greater than or equal to 24 weeks is the time we do the second time diabetic test. Okay, so this test is called as mainly DIPSI. So what is this DIPSI? So this diabetic test name is DIPSI. So this DIPSI is proposed by a single step. It is a single step test where you can see both screening. You can do both screening and also diagnosis in a single step. Okay, and in this test we mainly give a 2-hour OGTT. So what is this OGTT? Oral glucose. You give oral glucose, and this is total time 2 hours. This test take 2 hours time. So what is that? You will give 75 grams of oral glucose. Okay, by giving 75 grams of oral glucose, you will wait for 2 hours. Here no need for fasting before the test, anything. Whenever we want, we can do this test. Take 75 grams of glucose to the patient and wait for 2 hours, and next test for the blood sample after 2 hours. So if you see that blood sample, and if this blood sample its values, glucose values, if they are greater than 140, then it is you can say gestational diabetes. But if it is greater than 200, then you should say it is a overt diabetes. So by this DIPSI test, you can find out whether it's a pre-gestational or gestational diabetes very easily. Here fasting is not required in this test. Okay, so now coming to problems with diabetic pregnancy. So okay, now we have understood how to test it, everything. So what are the problems because of diabetes? If the mother is having diabetes, the problems are, first one is gross congenital anomalies. So there will be some congenital anomalies in the fetus. So they are also divided into two types, like according to gestational and pre-gestational. So what is seen in pre-gestational and gestational? First with pre-gestational, as I said, it is present from the first trimester. You know, many organogenesis will take place between first to second trimester. So there is a chance of congenital anomalies in pre-gestational diabetes mother, because the free radicals are easily passing by means of placenta from the day one of pregnancy. So it is a high risk. So there is a high risk of congenital anomalies in pre-gestational. But in gestational, you know, even though the free radicals pass, already it is between 24 to 28 weeks, so almost most of the organs are formed, so there is no that much problem in gestational diabetes. Okay, so because of this pre-gestational problem, we said high congenital defects. What are those? The most common congenital defect is cardiovascular problems greater than neural tube defects. So if you see, most common problems is cardiovascular defects when compared with neural tube defects. So as I said, the most common are cardiovascular. In that cardiovascular, what is the most common one? That is a ventricular septal defect. Okay, and what is the most specific anomaly? That is a caudal regression or sacral agenesis. So sacrum is agenesis and caudal regression, caudal part. Okay, so this is the most specific. Once again I am repeating, most common is cardiovascular diseases greater than neural tube defects. Among cardiovascular disease, what is the most common congenital defect? That is ventricular septal defect. Most specific is caudal regression or sacral agenesis. And what is the most specific cardiovascular anomaly? Most specific cardiovascular anomaly is TGA. Okay, that is transposition of greater vessels. You know, the great vessels will transposition. Like for example, in the case of superior vena cava or pulmonary trunk, there will be aorta. So like that, there will be transposition of great vessels. There is a most specific cardiovascular anomaly. And what is the most common cardiovascular finding? Here finding, okay, the finding is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common finding. And what is the test to predict this all anomalies in babies who are having this diabetogenic mother? The test is HbA1c. As we discussed before, if HbA1c is greater than 6.5%, ideal should be less than, it should be less than 6.5, right, percent. So if the HbA1c is less than 6.5%, then you can say it's ideal. That is in a non-pregnant or before pregnancy. At the time of pregnancy, it should be less than 6%. So by this you can say that this HbA1c values are directly proportional with the risk factors of congenital anomalies, right? Risk factors of congenital anomalies is directly proportional with HbA1c, because if HbA1c increases, then congenital anomalies increases, right? So what is the best test? What is the best test to detect all this? That is a TIFFA. What is this TIFFA? This is a level 2 scan, that is targeted imaging for fetal anomalies. It is done universally for all pregnant females, not only in the case of diabetes mother, even in non-diabetic pregnant female we do this to find out any congenital anomalies, especially between 18 to 20 weeks we do this test. Okay, and what are the ways to prevent this congenital anomalies, especially in diabetes mother, is nothing but the drug of choice is here insulin. So just we need to give insulin, and also we should give folic acid supplementation. Like we need to give 400 micrograms per day of folic acid, or also you can say 0.4 milligrams of folic acid per day should be given to prevent all these conditions. Now coming to folic acid supplementation in pregnancy. So how to give folic acid in pregnancy? Let us make it here. So folic acid supplement is also again divided into two types, that is the females who don't have any history, no history of neural tube defects. Here already history of neural tube defects. So some in previous pregnancy they may have neural tube defects, and in some there is no neural tube defects. So let us divide it. So if some there is no neural tube defects, then just give 400 micrograms per day, that is a prophylactic use of folic acid in them. Here even in a diabetic pregnant female you should give this 400 micrograms, already we discussed here, right? And in the case of history, already they are having history of neural tube defects, then give 4 milligrams. Here you should give 4 milligram because it's a therapeutic. Here it is a prophylactic, here it is therapy because now we need to treat this, already they are having neural tube defects. So especially pregnant females who are on anti-epileptic drugs, the dose of folic acid is given to prevent again neural tube defects. Okay, so till 3 months before pregnancy, or whenever a female plans of pregnancy, it should continue till 3 months after conception. So till 3 months we should continue this till 3 months, and even before 3 months of pregnancy we need to continue this folic acid, that is 4 milligrams. If already if the this patient is having previous history of neural tube defects. But in the case of this female who is a diabetic female and it doesn't have any neural tube defects in the past, then also we need to give 400 micrograms per day so that we can prevent the neural tube defects. So here we need to start giving it 1 month before pregnancy, here 3 months before, because already they are having a history. Here no history, so 1 month is enough before pregnancy, and continue till 3 months. Here we are starting before 3 months and also continuing till 3 months. Here starting before 1 month, continuing till 3 months. So finally after this, from 4th month, we have our 1 tab, we'll give 1 tab of ferrum, that is iron plus folic acid. Here we give iron plus folic acid, that is it is given under Indian program. We know this, already discussed previous video. So it should be given from the 4th month throughout the pregnancy, that is at least 180 days in pregnancy and 180 days after delivery. We need to give this, that is along with iron we need to also give folic acid. So till 3 months we are giving only folic acid, but from the 4th month we are also adding again iron. But remember, in the patients who are already having history of neural tube defects, we are giving this folic acid, that is 4 milligrams from before third month, before 3 months of pregnancy, and also after 3 months. Okay, and here if there are no history of neural tube defects, we are starting this folic acid before 1 month of pregnancy till 3 months. Okay, so by this we completed part 1. Next we'll start part 2 of diabetes in pregnancy.